Tēnā koutou katoa, my name is Darin. I'm a diagnostic imaging medical physicist from the Department of Medical Physics and Bioengineering at Christchurch Hospital in Christchurch, New Zealand. I'll be presenting the ANZSN NEMA Lowenthal lecture for 2021. This is a 30-minute lecture this year rather than the 45-minute lecture. It's just been cut because of program constraints. It's an honorary lecture and it's in honour of Dr. Gerhard Lowenthal, AM, who had a significant role to play in radiation physics and measurements across the Australasia area, and particularly for the Australian Atomic Energy Commission, which then became ANSTO. He is an honorary life member of the ANZ Society of Nuclear Medicine, as part of his honorary membership was granted because of his contribution to the society. I do have a few disclosures to make. I won't go through them all, but what I want to do today is just talk about some aspects of optimization. That seems like a bit of a crazy topic to choose for a presentation, because when we think about it in reflection, this conference is all about optimization of the various aspects of patient imaging and patient therapy as well. What I wanted to do was put on my Quality and Technical Standards Committee hat and jump up on my soapbox and just talk about the importance of performance standards and quality control, particularly in scanning. Now, the ANZ Society has some guidelines on these for minimum quality control schedule, for example, for cameras and the requirements for PET accreditation. But there are other agencies which do have requirements as well, or recommendations. It's just a sample of them. The one I did want to point out was the American College of Radiology one, because I'm going to talk a little bit about that in the quality control phantom. But there are a number around. Some are more oriented towards research than towards routine clinical practice. Now, just an example of some of the SPECT quality control tests I mentioned in that document previously on minimum and recommended frequencies. The one thing I think is missing from these documents, which the ACR program, the American College of Radiology program, has just shown an example here for spatial resolution measurement by putting the phantom actually on top of the gamma camera and looking end-on at the rods that are in the phantom. They have criteria for a pass-fail system for their accreditation scheme, and if you want, you can actually use those as a minimum criteria for performance of your system. So, for example, with this particular phantom, with the images on the left counted at 600 kilocounts, and no zoom, you should be able to see at least 4 sections of that phantom. So if your imaging system can't see that, then you need to be thinking, there's something wrong. I actually prefer to also do a high count acquisition, the one shown on the right, just to test the system to see, really what is the image quality in terms of spatial resolution like. The other one is SPECT Image Quality, and this is vitally important because you have poor quality flood scans or correction scans or uniformity, then you're going to get artifacts from their images, and we don't like artifacts in clinical images. We don't like poor quality clinical images in general. That's something we want to avoid, and quality control measurements are an important part of that. Example is that JZAC phantom or the ACR phantom. That's just showing the cold spheres at the top, the rods in the middle, and the uniform section at the bottom. People also like to measure some of the quantitative measurements of the contrast for those spheres as well. In PET imaging, we have something similar. We have for example, at acceptance testing, the NEMA image quality phantom. This is the one shown on the United Imaging System, the UM550 scanner. And I just wanted to mention that United Imaging actually did supply this NEMA image quality phantom with their system. So it's great to see a manufacturer endorsing performance testing and quality control checks on their imaging system. It would be great to see the other vendors follow suit. On a routine basis, I prefer to run I like to run as well, the ACR PET phantom, and this is where you take the JZAC phantom or the ACR normal SPECT image quality phantom, and you remove the sphere section and you put in this thing called the Esser faceplate. When you scan the phantom, it looks like this. It's got cold cylinders and hot cylinders, and you should be able to see a certain number of cylinders as part of the criteria for the ACR program, a certain number of rods within it for their clinical counting, but also I do like to scan it for a high number of counts. That's outside of your normal clinical counting, because what it allows me to do is to see what the system is doing in terms of image quality when it is not noise limited according to the collection at low counts or normal clinical count situations. So that's, if you like, a real test of the system. Also, apart from the image quality, this phantom actually does have quantitative measurements you can perform. Ignore the one on the left and the right. They're actually for two imaging systems, so don't compare the numbers. I just preferred the lovely coloured picture on the left. But the ACR have criteria saying you should be able to get numbers that are less than, for example, 2.8F with a 25mm cylinder, and you've got a certain value for background. The ANZ Society of Nuclear Medicine has a tighter criteria for that background measurement as part of our program. But what that does is allow you to check your quantitative accuracy, but also if your images are too noisy because you're doing something, your matrix sizes are too big, or your reconstruction filter is incorrect, it's just too sharp, or you are counting your bed times for the PET scanning are too short, then your noise levels are going to go up and you're going to fail that criteria. So it's a performance test for your PET system. I also like, though, with a new system or with new software and new algorithm, just to be able to compare across those different cylinders or vial sizes what the numbers actually look like in terms of the recovery, in terms of their actual accuracy. And this is showing an example for GE system comparing the Q-Clear algorithm with clinical counts using a normal reconstruction algorithm and for a high count acquisition and a expected vial concentration there as well. PET imaging, you also have to be very careful because you're high singles rates, and so you have to consider the count rate performance of the system. So as part of the NEMA test for acceptance testing is you put in a large activity, let it decay overnight, the system takes a whole lot of measurements during the night, and then it processes and it gives you this noise equivalent count rate curve, which is taking into account the measurements, the true, calculating out the trues, and the singles and the randoms component taken into that. So that allows you to calculate out, or the system to calculate out, the noise equivalent count rate curve, as well as you can look at the accuracy and how that changes with concentrations, your becquerels or kilobecquerels per milliliter. So these are important measurements or important assessment for quantitative measurements. And it's hard to do on a regular basis. So with the uniformity phantoms that I scan, I just do it at a high count rate and do it at a low count rate as well, partly to test the quantitative accuracy to see whether or not the numbers are changing with count rate, which we hope they wouldn't too much, and that's an important check. So whether or not your dead time corrections are working correctly, for example, but also to look at the uniformity across the images. And just to show you an example of sometimes where it is enlightening is on the right and in the middle are a high count rate acquisition using what I called an older OSEM algorithm, reconstruction algorithm, versus a newer one on the left. And I haven't named what it is because I don't want to identify the system. But if you look at the images on the top, you see there's artifact across the image. It's not uniform. There's a little band. And if you look at the coronal section on the left there, you'll see that there's actually lines through that as well. So what this isn't a count rate performance limitation we discovered. It's actually a count limitation. Because we were using a clinical imaging protocol at a high count rate, it actually had a high number of counts in the image. So this algorithm couldn't cope with high counts. So it's just showing the limitation. Now when you're working with these phantoms, you do have to be careful to be mixing them correctly. And the thing to keep in mind is that some of the phantoms, depending on the one that you're doing, actually can have a high dose rate associated with them. So you need to be careful about mixing them. You need to also be careful about the doses that you're receiving. We did a quick check one time looking at the mixing of the phantoms. I'm not going to go into that one, but just to say that when you've got phantoms that don't have any structures inside of them, then you can introduce an air bubble, shake it up, add the activity, shake it up, and then add the plain water back in again to top off the phantom. You've got to be very careful about the mixing of ones that don't have objects inside them. Ones that have got objects inside them, for example on the right with the ACR phantom, sometimes you can get away with just a little bit of agitation of them. Just like I said, be aware that when you're shaking them up close and things, depending on the activity in the phantom, you can get high dose rates. The second factor I wanted to mention about the optimization is administered activity, about implementing ALARA. And I wanted to mention this because officially now the ICRP have declared, the International Commission on Radiological Protection have declared diagnostic reference levels. People have been talking about them for years, but they're actually now talking about them officially themselves. And in ICRP 135, which came out in 2017, they now talk about nuclear medicine. So they talk about nuclear medicine diagnostic reference levels that have been administered activity, preferably activity per body weight. It's not surprising, is it? It's administered activity, that's what we do all the time. But they say weight-based adjustment may not be appropriate for certain single organ concentrations, for example, of thyroid or the kidney, the two that I'm just putting in there. They also say that you can, or they said you could adjust the activity up, and if there are sound clinical reasons to do that. For example, the patient's got significant discomfort and you want to reduce the scanning time, but you shouldn't be reducing the scanning time by doing more activity if you just simply want to increase the patient throughput. That's a no-no, which is quite sensible, isn't it, following the principle of ALARA. They also said to consider an upper limit for obese patients. ARPANSA have been looking at diagnostic reference levels for quite some time, and you would have seen their surveys come through. So on the ANZSNM website and also on the ARPANSA website are details about recommended administered activities, diagnostic reference levels for the various procedures. If you're above that, you really should be investigating why. What is it you're doing? Is it something you're doing with your imaging procedure that actually does require those higher activities? For example, you're doing some sort of flow situation. But the one problem I see about diagnostic reference levels is that they don't really take into account the science. They work on the collective as knows the best practice, which may be all right, but what happens if everyone is simply administering too higher activity? And this becomes a situation of importance, particularly in paediatric imaging, where you are doing administered activities to patients who are considered to have a higher lifetime attributable risk from radiation exposure. So we do need to be careful about those based on our current understanding of radiation biology. So different organisations have ways of adjusting the activity for paediatric patients. For example, the EANM has one based on maintaining a same effective dose or a constant effective dose as the patient weight drops. The North American and the SNMMI said, okay, we're going to scale linearly by weight on the basis that you maintain a pretty constant count rate at the detector when you're doing imaging. And there are other agencies as well that have got various guidelines and all have a minimum administered activity, to be very clear about that. So if you put some of these on the scale, and it's just showing an example here for DMSA scans, there's quite substantial differences in administered activity recommendations for different weights. So that's a bit of a problem. So we, as part of the nuclear medicine, or first nuclear medicine global initiative education on paediatric administered activities, went out and did a survey to see what people were using. And this is an example of the questions that were presented in the survey, and hopefully a number of you actually participated, but unfortunately not enough people really across Australia and New Zealand participated to get good local statistics. It's a little unfortunate, but a few things I picked up from the survey itself that weren't necessarily a scientific component were, for example, this question here, which was asking about the procedures performed, and we gave a nice list we thought was reasonably comprehensive, and another at the bottom. And what happened is that other turned from 12 procedures into 90 procedures. So it became a challenge and a half in order to be able to process that. So if you are doing surveys as this sort of data collection, be very careful about the questions that you're asking. The one that was the one question to rule them all, I said, is that if you had a particular scenario for a hypothetical patient for a 5-year-old boy or a 10-year-old girl, and ignore the numbers there, they're not real, they're just put in to capture the slide, what administered activity would you give? And this is quite enlightening because Dr. Uchiyama put the data together, Dr. Uchiyama from Japan put the data together, and if you look at the second column in on each of those graphs there for the 5-year-old boy and the 10-year-old girl, you'll see the EANM and the Society of Nuclear Medicine and Molecular Imaging recommendations for administered activities for that 5-year-old and 10-year-old, and a substantial spread about that, those recommended activities, for example, for Australia and New Zealand. So to me, we need action. We need to be thinking carefully about what we're doing, and we need to be collecting actually more data, and I believe ARPANSA are working on that as well. But I was interested in what happens when you go the other way, because it's actually a bit of an unanswered question in nuclear medicine. How do you compensate for the larger body habitus? Due to scale by weight, which means for a 140 kg patient you'll be doubling the dose or doubling the administered activity. So there isn't a lot around on this when we went looking. So if you, for example, this one I did find was on the Chapter 9 from the Physics and Radiopharmacy from the Nuclear Medicine Physics Handbook for teachers and students. And Richard Smart was advocating a power law factor brought into there by, once again, using that 70 kg as a reference point. So the graph on the right is technetium-99m mag3, just showing that that's the recommended curve as you start going up in weight of the patient for the administered activity. It might look like a straight line, it's definitely not a straight line. But we wanted to know what would happen if you modelled that situation. And one of the problems with the data collection is collecting sufficient numbers of patient examinations to get reliable results, and that's actually a real problem, both from getting ethics committee approval as well as actually processing and collecting the data and getting the numbers themselves out. So we wanted to know what happens if you started doing things like myocardial perfusion scans as a simulation to show you what the impact of body habitus was on the administered activities, or trying to use it to find administered activities. So this is an example of a study undertaken
undertaken by Miriam Dixon at the University of Canterbury for an MSc thesis, where she took the XCAT phantom, that's the extended cardiac torso phantom, and combined it with a Monte Carlo simulation. That's a random number simulation simulating the particle tracks and detection in the imaging system, emission from the patient and detection in the imaging system of the Siemens Symbia T2 gamma camera, which is what at that stage we were using for the myocardial perfusion scans. And from that, she made up a cardiac component or insert for that in that body organ, and filled it full of radioactivity in the myocardium, and also filled the blood vessels of the heart with it and things as well, or the heart with the radioactivity, but removed activity from the other contributing organs, for example, intestine, liver, etc. So we want to see what would happen in just the heart. And this shows an example down the bottom right there of some of the Monte Carlo simulations of the heart from that phantom, and also the SPECT CT scan itself, because it also gets a CT scan you can from this phantom. So that phantom is an example of one of the computational phantoms, these mesh type reference phantoms that can be scaled for body weight and height, etc., at different percentiles, or generally body habitus. And that's what Miriam did in this investigation. They look like weird patients. They were just a first approximation based on some of the limitations we had with that particular phantom, but got a range of body sizes from it, and did the simulations for those, looking at the simulations for no lesion in the heart, and then introducing a lesion into the myocardium and just looking at the detectability of that lesion. So it's not surprising that what we're seeing is that variation we see clinically, that large patients with the same amount of administered activity, we get, if you like, noisy images. But the problem is, what does that mean in terms of noisy? How bad is it? What do we use? So do we find a quality metric that relates to administered activity and simply scale that and figure out if we're going to stay constant with that value? And some people have done that, looked at, for example, noise indices. We maintain that constant value. How do we have to compensate with administered activity? Or do we resimulate with different administered activities and try and maintain some sort of constant image quality with that? That is possible with Monte Carlo simulations. It's one of the bonuses of it. You can do that without having to get ethics committee approval to administer more activity to patients. But it does raise questions about, how do you assess that? How do you look at the subjective image quality? Do you have to move towards quantitative measurements? So, as we know, there are a lot of factors that affect SPECT image quality in your acquisition process and also in your reconstruction process. So matrix sizes, number of iterations in an IOSEM algorithm, number of subsets, how you filter afterwards. Also throwing into that now the different reconstruction types, because we've got new hybrid algorithms. For example, the Siemens XSPECT Bone combining information from the CT component in these zones and using that in the reconstruction of the bone scans in the XSPECT Bone. And also the GE FAME, the Functional Anatomical Mutual Enhancement algorithm or approach, which uses functional data redistribution, and you see the substantial differences between the original and the enhanced on the left for their bone scans. But also sitting on the horizon are other reconstruction processes, one of which is deep learning, and it's already been used in the GE True Fidelity system, showing the images on the right there of a CT scan reconstruction with much lower levels of noise. And starting to see reviews coming out. This is by Reda earlier in the year, looking at deep learning for PET image reconstruction. So I think sitting on the horizon is more reconstruction algorithms, particularly based on artificial intelligence and machine learning, and deep learning for that matter as well, in particular I should say. Perhaps we won't see it for SPECT for a while, but I think it might not be too long before we see it for SPECT CT. The thing you have to keep in mind is we might get pretty pictures out of these, but we have to be cognizant of the fact that they may be affecting the quantitative measurements that we end up using or performing. So just to have that in mind, have that mindset that it's not just all about the pictures, it's about the numbers as well. So there are so many factors going to optimization. How do we deal with all of those? There's no golden rules for optimization. I've looked for papers, I've looked for the standard, this is the approach you take in textbooks and things, and I've never found anything. And I think it's just spread all across the literature as different approaches to doing it. You can think, okay, the collective expertise, go with the guidelines, but if the guidelines aren't up to date, it's actually not much use to us any longer, particularly these newer systems and newer algorithms. You can search the literature to see if someone else has done it, and hopefully it'll be evidence-based and published and reasonably comprehensive. But is it actually appropriate for your patient population and the disease you're looking at in your patients? Ask the application specialist. The suppliers do have a responsibility as well to be supporting the optimization of the imaging and an interest in that as well. But also the application specialists, they see the collective. They see a whole lot of different centres with a whole lot of different patient populations, and they've got a reasonably good idea, I believe, from what I've seen anyway, the really good ones, of the parameters for optimization. Phone a trusted friend and a learned friend. That is a thing that's often done in a smaller community, and it can be quite an interesting way to approach to optimization. You can reconstruct, get a whole lot of different variations and show a radiologist or a nuclear medicine specialist hundreds of images and say, are these okay? Don't know if you make any friends with that one. Or you can use appropriate phantoms for this, for the image optimization, for example that ACR phantom which I already mentioned, or use tools to investigate image quality and your clinical decision making. Now, in terms of those phantoms, this is an example of one we published or about to be coming out in final print recently for a thoracic spine phantom, where they fixed the number of subsets in their reconstruction and looked across the number of iterations, trying to find the optimal number of iterations for bone SPECT imaging. And they looked at 7 quantitative metrics for that and made a decision based on that a certain number of iterations were appropriate for their procedure. Now, these quantitative metrics are an example of your system-based metrics. So your signal-to-noise ratio, your peak signal-to-noise ratio, your contrast-to-noise ratio. Also, when you're comparing images, one versus the other, there's things like root mean square or mean squared error. And there's also this thing called structural similarity index, which some people are using. It's got a value of 0 to 1. And what it does is it compares the luminescences of images, or the brightness of the image, structural components and contrast components, and bundles them all together in this not magical index, but an index of structural similarity. How do those relate to the actual clinical decision tasks? And there's where the problem lies. Are they actually appropriate? And that really depends on the circumstances and what they're being used to detect. So there's alternatives, for example, your task-based metrics such as a subjective image quality, scoring on a 5-point scale, for example, in this situation, and comparing what happens when you start reducing the total acquisition time for a total body PET scan, and look at the impact on image quality, overall image quality, and image noise and lesion conspicuity. But there are the standard ones, sensitivity and specificity, example here of your filtered back projection versus iterative reconstruction for a system image-based parathyroid scans. And we are all quite familiar with the ideas of sensitivity and specificity. So these metric-based systems unfortunately can take a long time and a lot of effort to implement in your clinical investigations. So one of the solutions that's been touted is a numerical or a model observer. This process, or this observer, mimics the overall performance, human observer performance. And the idea is that you could use this at the early stages of development and then top it off, finish it off later on with actually a human observer study just to make sure you have got the final result that you should have. The most popular of these is the channelized hoteling observer. And it's just simply a series of filters which are designed to simulate the receptive fields of the human visual system and combining it all into one of the observer models. Also, the other one which we're starting to see now is one of those AI or machine learning is the convolutional neural network. And this is an example of an anthropomorphic model observer. So if you look at the top of the black line, which is a convolutional neural network, and the blue line, which is the average reader, as they've increased the amount of noise in the system, the metric on the left is the area under the curve, which is an indication of the performance of the diagnostic system. As I've increased the level of noise, the convolutional neural network has actually kept up pretty much with the human observer in many respects. But on the bottom, that's actually dived away quite substantially as the noise levels have gone up. And one of the reasons for this is that the one at the top is actually 3,600 training samples for that convolutional neural network. The one on the bottom is only 200, so perhaps reflecting a more realistic situation that might be part of a clinical trial or an investigation we might be involved in. So in this situation, the convolutional neural network hasn't really kept up with things. But there's developments going on in this area, and I don't think it'll be too long before we will have a reasonably robust observer for particular trained situations in order to be able to look at the optimization of imaging in particular diseases. So just summarising all of that, what we've now got for the optimisation of imaging, we can simulate human anatomy, we can simulate the imaging systems, we can simulate some of the disease detection, but there is more work to go on in that system. It leaves the simulation of pathology and pathophysiology. I'm not going to go into that because we don't have time, but there has been work in that area, and I think there is potential for more work in that area as well. If we combine all of those together, I think we'll have a way or a tool for looking at the optimisation of imaging, which isn't so laborious to the human participants. So just to summarise, I looked at the performance standards and quality control for imaging systems, and that is very important. We don't want lousy images as part of our clinical investigations or our trial investigations as well. We do have to be cognizant of the administered activity, and in particular our paediatric patients. There are so many factors to optimisation to consider. We really do need tools along the way for that journey in the path to optimal images. And of course, I've shown on these here as different components, but they are all interrelated to each other. For example, finding the appropriate administered activity as part of the optimization of imaging, and if we've got the tools to do that, that's great. So I think going forward, we do have these tools available. It is an opportunity for us to take a scientific look at the optimization of our area of nuclear medicine and molecular imaging. Kia ora koutou.